Hello, this is Dr. Marty Lustig, Principal with NextGen Advisors. Welcome to our podcast series. I'm joined today by my colleagues, Dr. Betty Rabinowitz and Graham Brown. Welcome to both of you.
Good to be here.
Hello, Marty.
In the wake of the pandemic that impacted the emotional and physical health of both those infected with SARS-CoV-2 and those who have so far escaped infection, the concept of whole person care seems to be gaining new momentum. Over the next few months, we'll be publishing some articles on this topic, with Betty exploring the historical context, Graham focusing on policy issues, and me looking at it from a clinical perspective. Betty, can you start us off by talking about how physical and mental health got separated in the first place?
It's a really truly kind of interesting historical tale. Very distant history clearly supported the belief that the human body was the vessel to the soul, and that tampering with the body was really sacrilegious and could interrupt the journey of the soul to the next life or eternity. And there was a very strong belief, therefore, that study of the human body, dissection of dead bodies was completely forbidden and not allowed. And this was propagated by very strict rules and laws by the church. Eventually, in the 1700s, there was a permission started in Italy in a medical school that was allowed by the church to dissect bodies, and that was huge impetus for the study of anatomy and the human body to progress. But then René Descartes came out with his theory of dualism, which basically said mind and body are two completely separate entities. Dissecting or studying the body is completely acceptable and okay because it is a completely separate entity that is unconnected, disconnected from the mind, the soul, and the spirit. And that mind-body dualism basically then for the next few hundred years was entrenched, supported. Any person who called himself a physician or anything on the way to it, the barbers, then the early day physicians, completely believed that their responsibility, their area of study, and their purview was the physical body, and the mind was left to clergy and others. So these are deep-seated separations that have very solid historical roots.
It's fascinating that it's goes back so far and is so deeply rooted in our consciousness as at least Western civilizations. So as you look more recently at the more recent history, how are we doing at sort of overcoming that?
I'd give us a 5 or a 6 out of 10. As a society, and again, Western world, as a society as a whole, there is still very strong stigma associated with mental illness and issues of the soul and the spirit and behavioral health, the discipline of behavioral health. People still feel much more comfortable in the realm of the physical body and its ailments. People feel more comfortable with divulging that they have diabetes than they do divulging that they have bipolar disease. So the society as a whole struggles still, and medicine as a mirror and a reflection of society has had some struggles as well. Physicians hold pretty strong biases in this area, but the good news is that in the last probably 50 years, both in medical education, medical practice, medical literature, medical research, the two parts are beginning to be whole. And that there's recognition of the tight and intimate and unbreakable bond between our minds and our bodies, and that the well-being of one impacts the other, and the illness of one impacts the other. And clinical models are evolving to support the care of patients across a continuum of mind and body. So 5 or 6 overall, 7 or 8 in our aspirations and intentions.
It'll be interesting, Betty. I like that you're giving us a 7 or 8 on the intentions and the direction that we're heading, but it's been a slow path as we look from kind of the 50s and 60s onward of the last century into where we are today. But there's been evolution certainly within how clinical care is being provided. And I know, Marty, that's an area that you're going to touch on a little bit. What are some of the clinical challenges you think providers are still grappling with?
Yeah, so I think for me, I kind of divide it into 3 areas. First, I look at primary care, and I think within primary care, there's both a capability and a capacity challenge that primary care providers have. I was looking at recent statistics in my own specialty of pediatrics, and the most recent survey results of pediatricians show that over 25% of their visits include a behavioral health diagnosis. And yet, if you look at how much of their training time in their residency program they spend on behavioral health, it's not close to 25%. It's a tiny part of their training. So there's a capability issue that's a big challenge in primary care, as well as they're already overwhelmed by the physical complexity of the physical problems that their patients have and the myriad of specialties that they have to know how to interact with. The second category are the behavioral health providers, who are very early in the process of having any appreciation of how physical illness plays in. In fact, many behavioral health providers have little or no training in physical health outside of those who are in psychiatry. And so how they develop the tools to even screen their patients for physical problems and know how to make referrals into the healthcare system, when many behavioral health providers have been pretty separated from the medical system for a long time. And then the third category, I think, are the medical and surgical specialists, who have the challenge both of deepening their understanding of how behavioral health issues interplay with the diseases that they care for and the procedures that they do, and then how do they incorporate that into the way they take care of patients differently than they have been historically. So that's kind of the way I would frame that.
So, there's certainly some challenges when we look at it from that perspective. I imagine there's some silver linings, to Betty's point, in terms of heading in the right direction. Where do you see opportunities for providers who are taking a more holistic approach, or for, community-based organizations that are integrating both physical, mental, and behavioral care?
Yeah, so to your point, I think that there is work going on at the ground level of actually bringing providers together, both in physical spaces and virtually, in order to collaborate with each other and develop processes that integrate their functions. And in some ways, one of the silver linings of the pandemic has been the explosion of telehealth. That makes it a whole lot easier for that kind of interaction to take place without the providers physically being in the same place. I think the other big tool that we have now is, in fact, the EHR, and the ability to embed screening tools so that whether you're a behavioral health specialist, a surgeon, or a primary care doctor, you can have screening tools in your system that supplement your own content knowledge and at least provide a front end for your patients to make sure that they're getting screened for other issues that may not be in your area of expertise. And then you have guidelines for when and how to refer those patients based on the screening. So I think that's a huge step forward, and increasingly artificial intelligence will help us navigate these kinds of issues, I think.
I agree with everything you said, Marty. I also think that there are now some very successful models of integrating into a single space, or at least a single organizational roof, behavioral health and physical health and dental health in FQHCs. So I think FQHCs, interestingly, have done a lot of work to destigmatize, create a continuum of care and caregivers for their patients to, if you will, a one-stop shop where you can go to the same physical space or under the same organizational roof, get your treatment for both. But it's only now that health information technology companies like ours, like NextGen, are creating truly integrated platforms that actually break down the silos between the data and the information of the different providers to flow seamlessly to all providers, so that you can see the behavioral health notes in your physical health charts, so that you can see the medication list from one in the other. There have been some barriers put up around privacy and the additional concerns of privacy around behavioral health issues, but even that in a certain way has been an artificial barrier that has gone up to maintain the siloed approach to mind and body, as if there's such terrible stigma associated with a mental health diagnosis that nobody can see it. It should be behind break glass. There's very little highly sensitive information. And for the rest, it's just medical information, whether it has to do with your mind or your body or your teeth. It should all be available to those people taking care of you. And I think we're making great strides in that regard. So, Graham, until recently, we didn't even have mental health parity laws in the United States. Can you tell us a little bit about government policies in this space and how we got to the current state?
Yeah, I mean, it builds on the historical separation that you referenced at the beginning, Betty, where, even within the United States, there was a separate construct for how behavioral health and mental health services were delivered, often through institutional environments and institutional settings. And those, it took through the 70s and 90s for a whole program of deinstitutionalization to be undertaken, wherein people were moved out of very large psychiatric facilities and into the community, and were starting to be treated in the community. It's around that era that we saw the evolution and really the growth of community health centers, community mental health centers and services, federally qualified health centers that were starting to bring these different needs of individual patients under one office. And in the 90s, there was the first, the Mental Health Parity Act passed by the Clinton administration that really looked at trying to bring some equity around how funding would be put in place, wherein it actually, so before, health plans could basically put a cap on the amount of coverage that they would provide for behavioral and mental health services. And the Mental Health Parity Act ensured that services there and the annual caps or lifetime spending could be no less restrictive than it was for medical and surgical care. So it tried to bring about some equity in that regard. But nonetheless, there were still caps in place. And there's lots of loopholes that have been put in place and still exist to this day. There was further, legislation in 2008, in 2010 with the Affordable Care Act and the High Tech Act, along with revisions to ERISA, the labor law for self-funded employer plans. All of those tried to bring about some level of payment parity, but in reality, for self-insured employers that have less than 50 employees, they're not required to provide coverage of this kind for mental health and behavioral health issues. People can still fall into a hole of not being able to get coverage. And if they do have coverage, it may still be with high deductibles, with all of the other kind of administrative barriers to care that are put in place along with physical care. So those things are still challenging. One of the really major issues was the criminalization of substance use disorder. And so if we think about people with addiction and how addiction is being treated, really it ends up having a lot of physical attributes to it in terms of addiction and the need to get a chemical into your system to calm you or to do whatever it's going to do, has a lot of physical elements, but can also be driven clearly by intellectual needs or by mental desires and physical needs. And so as a result of that, the whole war on drugs that came about really created a institutionalization again of moving people with addiction issues into the criminal justice system. And they have not been largely treated as a health issue, but rather are being treated as criminals. We see, as a result of that, over the last 40 years, the United States has 5% of the global population, but 25% of the prisoners that are incarcerated worldwide. There's a lot of implications for that, particularly racial disparities that have ensued and the impact on Black and brown communities around the United States. Those are, things that will take decades to undo. And there are legislative efforts now underway to decriminalize certain types of banned substances, but also look at the 3 strikes and you're out policy, where people with very minor criminal issues with regards to drugs or drug use have been moved into the criminal justice system. So those are some of the key issues that are still out there, but certainly, the absence of payment parity and that it's really being managed state by state in many situations creates this very confusing tapestry for providers that are operating in more than one location or trying to get services that, they may have had in one location before and are not if they move to a different community. So certainly that movement to reintegrate care and to provide holistic care to the person is heading in the right direction, but there's much more to come.
Absolutely. What do you see as the major policy issues that need to be addressed going forward based on these kind of realities?
To me, it falls into kind of similar to what Marty was saying, it falls into 3 main categories. Implications for policymakers around health insurance coverage, state and federal funding, what the fee schedule should be in terms of paying people adequately to take care of individuals with behavioral and mental health issues, and then ongoing efforts to look at decriminalization and or incarceration for folks that have addiction issues. There's implications clearly for medical schools, nursing curricula, but also to your point around for social workers and psychiatrists, that cross-training in mental and physical health. Along with research into this area, there was a huge amount of research that was being funded federally that kind of dried up in the 50s and was prevented from being funded in terms of innovations in mental and behavioral health care. That's starting to change again, but there's a ton of research that's really lagged behind in decades in this area. And then the implication for providers is around how they create alliances at a local community level to really solve this, because this isn't going to get solved at the federal or state level. It's really going to be solved community by community. And so organizations that are providing this type of care, either on the physical or behavioral health side, how they work with their community partners to really look at the whole person that's in front of them and give them the services they need, either through a referral basis or bringing things in-house or creating clinically integrated networks or referral networks where they can address those patients' needs.
Well, Graham, you've given us a lot to think about. Thank you. Thanks to both you and Betty for sharing your perspectives. And thank you to our listeners for joining us today. If you enjoyed today's discussion, consider subscribing to our podcast. This is Dr. Marty Lustig with NextGen Healthcare, and have a great day.